Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the geographical, continuous versus fixed duration of therapy in newly diagnosed multiple myeloma patients by Antonio Palumbo et al. My name is Shaji Kumar, and I am a hematologist at the Mayo Clinic in Rochester, Minnesota, USA. My oncologic specialty is plasma cell malignancies. The one indisputable fact in the field of multiple myeloma is that there has been a dramatic improvement in survival during the last decade. The treatments in myeloma have significantly changed over the last decade with introduction of several new classes of drugs, such as the proteasome inhibitors and immunomodulatory drugs. These drugs in combination can lead to deep responses in myeloma, hitherto unseen even with high-dose therapy and autologous stem cell transplantation, and are associated with manageable toxicity, opening up the possibility of long-term therapy. The primary goal of myeloma, still considered incurable, is to obtain disease control and prevent defense. These developments have set the stage for asking two important questions, namely, how deep a response should we target, and how long should we continue treatment to get the maximum benefit in terms of reducing risk of relapse. The depth of response is a moving target with increasing sensitivity of tests for tumor detection and is dependent on the intensity of initial treatment. In the context of prolonged therapy, no markers exist that can inform us when continued treatment no longer has an additional effect on the residual disease clone. If the drugs were inexpensive with little toxicity, the debate would have been muted. So the decision to employ intense therapies and to provide continuous therapy till progression should be based on demonstration of overall survival improvement. But we are victims of our own success. The plethora of new and effective drugs has led to unprecedented survival for myeloma patients, making timely assessment of a new drug or a new strategy nearly impossible. Given the scenario, we need endpoints that can be achieved earlier and are meaningful to our patients. Dr. Palumbo and colleagues have attempted to answer these questions in his pooled analysis of 3 different trials that addressed the question of continuous therapy versus fixed duration therapy strategy. The study was designed to ask a simple question, one that we ask ourselves in the clinic every day. For a patient who has completed a defined duration of initial therapy, do we stop or do we continue until disease progression? In the current study, outcomes were assessed from a new starting point 1 year from initial randomization, representing the completion of an appropriate duration of initial therapy. The outcomes observed in these two otherwise comparable groups of patients provide results that can have broad implications for the clinical practice, as well as future clinical trial designs. The analysis showed an improvement in overall survival with continuous therapy, an effect that was seen in all the subgroups tested. One of the arguments against continuous therapy is the assumption that patients can be easily salvaged at the time of relapse. However, myeloma relapse can present with life-threatening complications related to the disease, which can easily spiral out of control, leading to death. Not even close observation of these patients may prevent timely intervention, as we have learned from patients with MGUS progressing to myeloma and presenting with catastrophic complications. The time period that a patient spends in the relapsed state is a vulnerable period that can be complicated by risk of infection, toxicity related to a new therapy, as well as other disease-specific complications. In the current study, there were 4, 7, and 21 excess deaths in the fixed duration cohort before first progression, second progression, and subsequent to second progressions, respectively. What is not clear is whether these deaths occurred despite easy access to the drug that patients in the continuous arm were receiving. From a biologic standpoint, recent studies have shown considerable genetic heterogeneity in myeloma cells that result from clonal evolution, and this process is enhanced as clones re-emerge from disease relapse. This is another argument often used to support continued therapy. However, this has to be balanced with the potential deleterious effect of this approach. There is clearly toxicity and impact on quality of life related to being on continuous therapy, an aspect not examined in the current study. These are particularly important as the median duration of therapy in the continuous therapy group was 22 months, while the median PFS was 32 months, suggesting that many patients went off therapy before progression. Why did they? If we are to implement the results in our practice, does the data support its use beyond the 2 years that these patients stayed on continued therapy? A trial currently enrolling in the Eastern Cooperative Oncology Group, E1A11 or Endurance trial, is asking the question of ideal duration of therapy in a prospective fashion. While it may be anathema to talk about cost of care from an individual patient standpoint, continuous treatment approaches translate to a huge cost for the society, and serious discussions on the cost of medicines is in order if we uniformly adopt this approach. Finally, myeloma is a heterogeneous disease, and one size likely does not fit all. This is exemplified in the study by the reduced benefit seen in the older patients, and likely there are other factors that have not been explored here that may allow us to select patients for either approach. The important finding is the relevance of the second progression-free survival duration, abbreviated as PFS2, a relatively new endpoint that is increasingly being used in clinical trial designs. As Dr. Palumbo points out, European regulatory authorities have started requiring its inclusion in many of the ongoing clinical trials. Why is it important? One of the concerns of prolonged therapy is that it may lead to resistant relapses that cannot be optimally salvaged with available treatments. Inclusion of PFS2 allows us to assess the impact of the first 2 sets of treatment, including the interaction, if any, between the 2 treatments, either in the way of increasing toxicity or enhancing efficacy. The current study shows that continuous therapy leads to not only improved PFS1, but also improved PFS2, suggesting the lack of any long-term deleterious effect of continuing therapy. The current results also suggest that PFS2 is a valid surrogate for clinically meaningful benefit, where the overall survival benefits may take a long time to become evident or may be unduly influenced by rapid pace of progress in cancer therapy. So what can we take away from this study? Continuous therapy till progression appears to improve survival in patients with myeloma, and the option should be discussed with patients, while also highlighting the unknowns about the long-term toxicity and the impact on quality of life. Studies should be designed to identify patients most likely to benefit from this approach, allowing us to personalize the treatment of myeloma. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.